Are we rolling?
We are rolling.
All right.
Alrighty. Hello, everybody. Welcome back to our second episode of our clinician interview series. Today, I am joined by an amazing professor in the Boston University Physical Therapy program, Dan Sieczkiewicz. Dan is an amazing both physical therapist and an amazing teacher. In fact, I've even TA'd for you this past summer.
You did.
And it's honestly...
Very well, I might add.
Oh, yes. But honestly, it's truly been a pleasure just getting to know you over these past several years and seeing you work with patients. I'm really excited to hear more about your perspective in treating those who are struggling with chronic pain. So I guess just to start off, I'd love to just know, tell us a little bit about yourself, how you kind of came about as a physical therapist, and how long you've been practicing for.
Yeah, so you're going to make me date myself here now. So I've been a practicing physical therapist for 15 years.
Wow.
So graduated from this fine institution in 2009. My journey to physical therapy, and there's no really knock your socks off type story with it, aside from I had my own experiences with injury, primarily through my sport at the time, which was running. And I had my share of interactions with healthcare providers related to things that I had experienced. And I thought, hey, this might be something that would be fun to do. I like to help people. And then, going through school, it started having second thoughts. Oh, is this really what I want to do? But then got to the professional part of the program, and that sort of solidified to me, yeah, this is it for me.
This is my spot.
I had dabbled in things like pediatrics for clinical experiences, neuro, all of which gave me positive experiences and kind of molded me ultimately to being a professional physical therapist upon graduating. But outpatient orthopedics is sort of what was my initial draw. And then after testing the waters in other domains, ultimately came back to outpatient orthopedics, which is a setting where, I'm sure as you know, we do see many patients who experience chronic pain.
For sure.
Which is what we're here to talk about today.
That is indeed what we're here to talk about today. So obviously you've seen a wide variety of patients struggling with chronic pain. I mean, I feel like oftentimes the conversations kind of lean towards low back pain, like chronic low back pain. But there's such a wide variety, fibromyalgia, and just it's really interesting to see even in the clinical experiences I've had these past 2 summers. It's wow, it really can manifest in so many ways. I think, do you ever, what has been kind of the journey of that? Because initially when I think a lot of PTs see a person with chronic pain who've been struggling for anywhere from 6 months to a decade even, that could be pretty intimidating. How did you feel when you first started, when a patient came in with something I've been struggling with this for years? Yeah,
when I was a younger therapist.
When you were a younger therapist.
Well, also, because that was so long ago, we didn't have a lot of the same tools then that we do now.
Yeah.
Right. And as I'm sure you know, and your audience knows, the dissemination of new information into practice takes a long time.
Right.
So perhaps 15 years ago when I first started treating patients, maybe some of this stuff was known, but wasn't mainstream clinical practice. Perhaps it still isn't. We just didn't have the tools that we have now. So if you take someone who, say, comes in with a diagnosis of fibromyalgia,
right,
which we used to see that term a lot more. I think we're seeing it less a bit now.
Yeah.
It was essentially, we're going to try the things that we're good at doing as physical therapists, which is manual therapy, exercise, some educational interventions, but nothing like what we do now. So I have to say I probably failed a lot. There were probably a lot of people that were coming in hoping and expecting to get better that didn't, because I didn't have the skill set that I currently have.
Yeah.
And if I back up even a little bit more, the sorts of things that you guys learn now in school, in spine class is probably where a lot of it is sort of loaded, because chronic low back pain is pervasive.
Very.
your education, your preparation to go into the workforce looked a lot different than mine, but we did the best with the skill set that we had. So I think it's important to be adaptable, be a lifelong learner.
Yeah.
And as new information comes out, incorporate that into your clinical practice. So just didn't have the skill set that I do now. So it was quite intimidating. And that could be true not only for people with chronic pain, but if before I did a manual therapy fellowship and knew how to effectively manipulate joints, if there was a patient that was appropriate for it and I didn't know how to do it, like that's intimidating. Or if I was just learning how to do it,
right,
that's intimidating. So I don't know that it's unique to people with chronic pain. It's
right.
Anytime someone comes your way and you don't have the skill set or you're not confident in the skill set to manage that, it certainly is intimidating. For sure.
What would you say are like the primary like things to have in your toolkit for treating somebody with chronic pain? Like, for example, what are some like of the main skills that you use, especially if a patient's coming in for the first day? Patient comes in, they want to be seen. Sometimes they've been seen by multiple providers who have just said, I don't know what's going on. And they don't know what's going on. Like, what sort of skills do you find most helpful in treating these patients?
So the toolkit would consist of like things that you would typically expect to see in physical therapy. So exercise, manual therapy. Individuals with chronic pain still benefit from those types of interventions. Dosed differently sometimes than someone who, say, comes in with acute pain.
Right.
So that's still part of the toolkit. In addition to that, having strong like educational principles. So like you need to know how pain works and know how to communicate that to your patient, which if you're talking about someone coming in day one, where can you make the most amount of impact? If someone has had pain for, say, a year. You're not going to give them one exercise on the first day that's going to start to move the needle on that pain experience. But if you, and again, maybe in the toolkit as it relates to educational interventions and communication strategies, part of that would be having a skill set in how do you talk to your patient. So that could be something like motivational interviewing skills, right? So how can I have a conversation with this patient to first learn, so active listening, learn about what their pain experience has been, learn about what they've come to believe as being true, about what it is that's going on in the painful body part, and then having strategies to start to slowly challenge that. And that could be, motivational interviewing strategies are one skill set that you could use to enhance your communication. So to summarize that, I would say day one communication is extremely important.
Right.
You're probably going to make the most amount of impact just by the way you communicate and elicit information, offer advice. But don't abandon the things that we also do well, which is prescribe exercise, perform manual therapy techniques. So those things are still part of the toolkit. I think the what rises to the top though on that day one is communication.
Absolutely. I think that's a great point. I mean, even just I talked to like another clinician just the other day, and I think the biggest thing that they talked about was that communication aspect, that listening, and how sometimes like it's okay to not do as many of those observational
objective.
Yes, thank you. I was like, wait, objective measures. Because I think it's really easy to fall back on that because it's a number to use and it's a number to be like, there is progress. And I feel like there is plenty too. I know in this clinic, they use the central sensitization index, as like a sort of initial marker, but even just talk about like the patient specific functional scale, like as something that's like, it's not necessarily specific to a body impairment, but it's very relevant and specific to the patient and what their goals are.
Right.
And I think that connection piece that you're talking about is so important. So I love that.
And can I add to that?
Absolutely,
briefly?
please.
So people might be wondering like, okay, I get it. Like I need to have a conversation with this patient,
Right.
understand where they're coming from, what their attitudes, beliefs, behaviors are surrounding their pain experience. But that's sort of abstract. And like, how do I actually do that?
You're getting to my next question. I love it. All right.
So I think what's probably most important, if you want this to go well, probably the first best thing that you can do is place your patient right smack dab in the middle of that conversation. So essentially having a patient-focused approach or a patient-centered approach.
What does that look like?
Yeah. So you mentioned things like patient-specific functional scale.
Yeah.
So essentially you're asking them to say what has been most impacted in your life by the pain that you're experiencing.
Yeah.
So that's a good place to start. So standardized outcome measures are helpful. There are items even, we have people fill out the start back tool as part of their intake paperwork. There's a box on there that people can tick that says, I think it's terrible and it's never going to get better.
Right.
So you can say agree or disagree.
Yeah.
So if someone checks agree to that, you can use that to say, I noticed that on your intake paperwork, you checked that you think that this pain is terrible and it's never going to get better. Are you comfortable telling me a little bit about, what goes behind that belief?
Yeah.
Right. So asking open-ended questions and placing your patient at the center of that conversation. What if you don't want it to go well, which I don't imagine anyone who would want that.
I would hope not. Yeah.
If you don't want that to go well, you could come in citing a bunch of evidence, try to be a smarty pants, very top-down hierarchical approach to patient education.
Right.
And you're likely to be met with resistance, which is okay.
Yeah.
Right. There are times where I love when I get resistance because to me that indicates that my patient's listening.
Yeah.
They're having feelings surrounding what I'm saying.
They have a stake in
Correct.
This. Yeah.
I would much rather that than the yep, that makes sense. Yep.
It's like
you want to invoke some sort of reaction. And not to say that you want to argue with somebody.
No.
But you want to invoke some sort of reaction.
Right.
Right. And if you just go in citing evidence, you're probably going to hear something like, yeah, well, that doesn't describe me. Yeah. Right. And then where do you go from there?
Yeah. And I think that's such an interesting point too, given that there's a lot of research on just like the impact of pain neuroscience education or pain science education, as it's sometimes referred to in the literature as part of patient care for those struggling with chronic pain. But I feel like, a lot of that issue can come up, like you talked about with, that just means giving them the evidence on stuff. But that's not how it really is. I feel like you said, it takes away. It's a top-down approach rather than bringing the patient to the center of the stage and saying, like, this is about you. So, I think it's still very valid to provide that education. The literature is saying something there.
Absolutely.
So how do you kind of bridge that gap? How do you provide that education without seeming like you're just citing the evidence? Like, how do you approach that?
Yeah, good question. My strategy as of late is to come more from a place of being curious. Right. And as you're conducting a patient interview, as long as you're asking open-ended questions, your patient's going to tell you their story, right? If we ask yes/no questions, you're only going to get information related to the things you're asking. Right. So when you ask open-ended questions, you're going to get a story. And if someone's had pain for a long time, there's a lot to tell. Yeah. So what it seems to be helpful is if you take little anecdotes from the story that they've told you that are good examples of what we know to be true related to pain neuroscience. Yeah. So you can take that little anecdote. I would maybe repeat it back to the patient and say, I'm curious why that happened, or I'm curious why, your body responded that way, because here's what we know about blah, blah, blah.
Yeah.
Right. But which is much different than, well, we know that pain is just an output from your brain. So, but if you can attach an example, especially if it's something that your patient has lived, it's a lived experience from your patient. Yeah. And attach that to something we know to be true about pain neuroscience. The impact seems to be much greater.
Yeah.
Perhaps second to that would be if you don't get anything in their experience that is, gives you enough firepower to do exactly what I just said. You can use experiences from other people you've worked with that relate to a concept of pain neuroscience education.
Mm-hmm.
But attaching it to something that's a bit more tangible, at least from an educational perspective, seems to go a long way. So I would say be curious instead of
educational,
argumentative, maybe, or
or maybe instructive.
Yeah, sure. That's probably a better word.
Yeah, because you are being educational, but like it almost like, oh, I'm instructing you to do this. It's like I want to learn more,
right?
And I can help you learn more,
right?
As well.
Yep.
Let's learn together.
Yep. Yeah. So be curious.
Yeah.
Try to make it relevant again, so patient centered.
Right.
And then you're just looking for small opportunities to kind of work your way in there to provide some education.
Yeah.
Asking permission to offer a different viewpoint can also go a long way.
Like what?
Providing some choice. So you might ask, so if somebody were to say, my muscles just feel stiff all the time.
Yeah.
Right. I might follow up with, well, what do you think it is that contributes to them feeling stiff all the time? You get a wide variety of responses. Be prepared for a wide variety of responses.
Yeah.
But hear them out. See what they have to say.
Mm-hmm.
And then, I could see why, you would, find that to be true. There are alternative explanations if you're curious about hearing what those might be. So just today, I was involved in a co-treat with someone where we were introducing some of these concepts, mostly as it relates to quantitative sensory testing and sensory integration training.
Oh, yeah.
So I asked, do you have any questions on this, or do you see how this could potentially be helpful for you?
Mm-hmm.
And the patient was like, yeah, but I think ultimately my muscles are just stiff.
And that's
which I love. Fantastic.
Yeah. That tells you so much about their perspective.
So, okay, we're not there, and that's okay.
Yeah.
But now I need to figure out a way to get there.
Yeah.
So the way I handled that is trying to talk about the muscle stiffness, because that was very important to this person.
Yeah.
So talking a little bit about muscle stiffness and how that could be at times a tissue property, meaning that the tissue just does not move easily.
Mm-hmm.
But we've assessed that, and it looks like your mobility is good. It sometimes hurts to move, but the amount that it moves is pretty good.
Yeah.
So even though your movement is what we would expect to find, you're still feeling stiff.
Right.
So stiffness, alternatively to being a tissue property, is also a sensory experience.
Yeah.
So working on managing or tempering or fine-tuning maybe the sensory messages can help with that muscle stiffness.
Right. It's their experience ultimately.
Correct.
You can't disregard that.
It's not up to us to say, well, you're not stiff.
Right. It's like,
I tested it, you're actually not stiff.
Yeah.
So I understand that you feel stiff.
Mm-hmm.
And stiffness can be because of tissues not moving well, or stiffness can be a sensory experience.
Yeah.
Right? Which relies on you getting information from that body part, your brain processing it, and then you feel the stiffness.
Yeah.
So if maybe there's a place for working on the tissue property part of things, but also working on the sensory information part of things.
And I think we're going to take a break in a short little bit, but especially so thinking about, okay, you have that person saying, well, I still feel stiff.
Yep.
what other approaches like would you think about trying to kind of help resolve that sensation of stiffness? Like what sort of intervention?
Like, what does the treatment look like? In other words?
Honestly, because I feel like you can be like, okay, well, I'm doing stretching of the muscle. It's like we've done a bunch of that, and I'm seeing that we've increased whatever it is, hamstring length or anything like that. And you go,
but I still feel stiff.
But they still feel stiff. What do you do? Like, how do you kind of? And obviously, it's probably not something that's going to happen overnight, obviously, over one session. So what is the approach in that?
Yeah. So if we're taking that to mean that the stiffness this person is experiencing is not from a tissue property, then the alternative explanation would be that you're feeling stiff, and the stiffness is a feeling, and you're using that word to sort of describe what it feels like.
Right.
So then it makes sense to have an intervention that would maybe change what it feels like.
Yeah.
Right. So that's where I think sensory integration training could come in and be helpful.
Gotcha. Right. All right. Well, we'll take a break and then we'll come back and talk a little bit more about what that actually means. So we'll be back shortly.